Great distinction, and a rounded applause, if you would, for our honor professor today, Dr. Hanssen. Okay, look at him and hold it up. And now I turn it back over to the chairs.
Okay, I hope I can advance this okay. No, thank you, Kevin. Those are very kind words. I am going to talk to you about prevention and treatment of instability. I'm glad I'm doing it here with this session because, Kevin, you did a great job putting all the articular choices up there.
It should be forward.
Yeah, I got it. I have some disclosures and a couple things. My disclosure with Stryker is very specific to the dual mobility. I do receive royalties from that. I'm going to make an admission, just like Kevin was suggesting, that when we first started nosing around with dual mobility, I was the one person in the room that thought it was the dumbest idea I had ever heard in my life, and I was very vocal about that. And I'll leave it to you as the audience at the end of the talk to think of whether I've changed my mind or not. We all know that hip instability is one of the most common and dreaded complications by patients and surgeons. It's definitely been a driving force for large head technology, and there have been a lot of advances actually in this area. We've all had to look at this and think about this in our training and every day as we go through to look at all the different risk factors. And this list, although very extensive, I'm going to try to cover somewhat in the next few minutes. We all know that surgical technique is really important, and despite what everybody disagrees with, some of my partners who are posterior advocates will switch their approach on high-risk patients, and I still believe that the posterior approach has the potential for a higher dislocation, and you should be aware of that. All these other variables with the acetabulum femur are all things we can do in the surgical technique that help us avoid instability. And I'm not going to go in those in detail. You know about those. I'll address a lot of these subsequently here. The name of the game with dislocation is impingement. That's why people dislocate unless they have no abductors and it just falls out. That's what we have to be thinking about is how can we avoid impingement? And I'm going to keep hammering that as we go through, but impingement is the whole reason why we have dislocation. And one of the most interesting things that's happened over the last 5, 6, 7 years is the realization about how much lumbosacral pathology affects hip stability, and this has primarily only been addressed in primary, but it obviously has to be involved in revision. But there are all kinds of articles out there now, and this is Larry Doerr's concept of this. You can see drawing all the angles, pre and post-op, where the femur ends up. It's a very complicated analysis, and I'll point out, it's not just the analysis, patients themselves are very complicated. And not only that, we know that pelvic stiffness and lumbosacral issues change over time, or they get eventual surgery at some point. So this is just an example in Larry's recent article of a stiff pelvis showing that during sitting, this one is at risk for anterior impingement unless you adjust your acetabulum at the time of surgery. So what he has proposed is a functional safe zone rather than the typical safe zone of Lewinnik that we're aware of, and does this in a very complicated way, looking at all these angles. What he found, though, is that the typical safe zone we thought about, there's a fairly high percentage of patients, and this one was 14%, that are in that zone but are not in the functional safe zone. And this is actually accentuated if somebody's got increased femoral mobility preoperatively and postoperatively. The stiff pelvis with increased femoral motion is at highest risk. So what can you do to avoid impingement in this situation? First of all, you have to try to identify it. And then one of the things you can do in surgery, and I don't know that people do as good a job with this as they should, is change your routine to try to figure out, is the patient impinging? Where are they impinging? Do I need to change something with the femur, with the offset, with the length? A lot of times you just sort of do this, that's good, and you get out of there. You're running multiple rooms. In addition, the question is once you've made all these determinations, can you actually put the cup where you want to put it? And that's why there's the interest in navigation, robotics, smart tools, et cetera, to actually try to do a smaller scatter on where you put these cups and adjust it correctly if you're going to adjust it. So he comes up with the stuck standing and the stuck sitting, which if you know Larry Dorr, he comes up with some weird stuff. Basically, the stuck standing is an anterior pelvic tilt versus the stuck sitting, and he's got a number of values there. His final conclusion is maybe you should just consider dual mobility when you have all these problems and not worry about all this. And I can tell you, at the most recent closed member hip society, there were a number of people who actually said, I can't follow all this math, I can't do all this goofy stuff. And people standing up and saying, I just changed my approach. I do a direct lateral approach of the dual mobility and forget about it. Matt Abdel, who's one of my younger partners, tried to come up with just a simple thing for people to look at anterior stiff, posterior flexible, posterior stiff, how do you change the anteversion? But it's actually much more complicated than that because of changes over time. Is the sacrum involved with the pathology? And Matt, even as a young guy, just said, listen, I'm just going to do dual mobility in these situations and get out of here. We can talk on the panel more about all these values. So what can you do in these situations in the primary setting? Well, I think there's newer pathologies coming on to identify all this dynamic data, inputting it to software, try to simulate functional motion and change your cup, but you're going to need to have something that allows you to do this more accurately. Now, I'm going to move on to revision. Most of what's been talked about here this afternoon is primary, but we all know that revision surgery is actually an independent risk factor itself for instability, and of all these things that are high risk in revision that you see on the screen, revision for instability itself is the highest risk for recurrent instability. And when we talk about treatment for instability, basically we're talking about doing the usual things that you all know about, revising malposition components, upsizing the head, optimizing offset and length, advancing trochanters, or the considerations of articular constraint that we all just talked about and I'm going to continue to talk about. Most people would agree when you do a revision, you should probably upsize the head as much as you can. And you know, there are certain situations where you might do lateralized or face-changing liners. But more and more people are migrating in these high-risk patients to articular choices. You'll hear some guys like Tom Skalko say, I just put a constrained liner in. I'm old enough to know that I've had a lot of constrained liners fail. They fail more than people talk about. And despite the fact that I was so down on dual mobility, I was pleasantly surprised over the last 5 or 6 years at how I could pull this off. And I'm going to show you some interesting studies we've done at the clinic that have increased our enthusiasm for this construct in the revision setting. So I'm going to go to here. What are the indications? They're not really completely defined at this point. One thing's for sure, though, there's evidence for expanded indications in a number of these patients in the revision setting and in the complex primaries like the spinopelvic or a variety of other conditions. So why is this happening? Well, as we all know, the Europeans have been doing this forever, and we all know we don't trust their data. And part of the reason I think that it happened is most of what they were doing is cemented dual mobilities, and we didn't want to cement cups. But once it became obvious we could do cementless cups with dual mobility, and metal and metals imploded, all this happened simultaneously. All of a sudden, people wanted to still use larger femoral heads and a cementless cup. And that's actually how we got to where we are now. This has happened over probably the last 7 or 8 years. So if we look at the literature, this is one of those European studies, but they look just at revising people for instability in this registry. And I want you to remember these numbers. Recurrent instability was 9%, but in the dual mobility, 2%. And that's a number I'm going to keep coming back to. We got the Hip Society Award a couple years ago for this paper. And what we did is we said, let's just look at all-cause revision, dual mobility versus 40-millimeter heads. And you look down there, dislocation. And these are 40s. They're not 36s, 32s, they were 40s. Dislocation rate in large femoral head in that first line, 10%. Dual mobility, 3%. One of the things I'll point out is almost all the patients that were being revised for instability were in the dual mobility group. It was a biased group towards dual mobility. And yet it was 3% versus 10%, and all the reoperations and stuff because of instability. It's been well known, Tom Ferring, who's in the audience here, pointed this out. Those of us who have been doing this for years know that in reimplantation surgery, dislocation is a problem. We just looked up and reported earlier this year on over 500 two-stages, and we looked at traditional large femoral heads versus dual mobility constrained. The indications were whatever the surgeons wanted during that time, but look at that. At 5 years, the traditional femoral heads, 13% dislocation. If you drop down to constrained, 9% dislocated their constrained liners. Now, they're bad cases, I get you, but I can tell you at the time we were doing these, we weren't that happy or hadn't bought into dual mobility, and look at that number, 2.7% compared to the other groups in reimplantation. So at the end of my career, didn't matter who it was. When I was doing a two-stage, I'd put in a dual mobility. So Rob Truesdale came up with this idea. He always comes up with goofy ideas. He said, what are we going to do with the multiply failed constrained liner? We had a group of patients that had an average of 4 constrained liners. We've all been there. You put it in, you go back, you change it, you do this, you do that. So he says, we're just going to start putting dual mobilities in these people. Solved 70% of the problems with failed constrained liners on average of 4 times. Some of them still popped out, but still, 70% is a pretty good thing for multiply failed constrained liners. One more study before I move on. This is a paper just on obese patients in revision surgery from abroad by Hernagau. And look at again, very similar numbers to our cause in the reimplantation. Again, dual mobility, 3% roughly for instability. I think Spore is liking this talk. So, as you know, recently there's been a plethora of meta-analysis and systemic reviews. And it's funny, in this 3-year span, there were 4 of them. I'm going to highlight the last one. Nick Reina was one of our French fellows, and he got all the French literature combined with this. And we did it for primaries and revisions. I'm only going to show you revisions in the interest of time, but there were 6 papers that qualified for this. And then you look at the top line, absolute dislocation, 2.2% for dual mobility. Controls, 7%. And then all the other things, look at aseptic loosening, for instance, has a risk ratio of 2.7 compared to dual mobility. So dual mobility in the revision setting with this review is a home run compared to the other options. So what are the indications? I can't really tell you. I never did them for primaries except spinopelvic mobility problems. There are a lot of people who are actually doing that more and more, but I can tell you most of my practice was revision surgery. I became a very, very aggressive user of dual mobility in the revision situation, and I think with good reason based on the data that we have. So you'll say, yeah, but it costs so much. Well, Matt and Mark Pagnow and I took that Hip Society paper for all-cause revision and looked at reinterventions over 3 years following surgery based on that data, and look at the bottom line. We save $1,500 in Medicare patients, $2,600 when you compare implant cost acquisition to reintervention costs over a 3-year period. So it's when do you spend the money and when are you having your problems? Yes, it is a little more expensive, but in the high-risk patients, it might be the lowest cost option on a long-term basis. So in conclusion, what I would tell you is, in the primary, one of the newest things that people have been focused on is the spinopelvic mobility in the functional zone. I would remind you that you constantly have to be thinking about how to eliminate impingement that you see in the OR. And I think that even as an old guy, like Juranic would say, I think some of these new technologies coming down the line for more accurate acetabular position are going to be a game changer in hip surgery. And in the meantime, I think dual mobility mitigates a lot of that risk for some of these complex patients. In the revision setting, I dare you to say anything else except that we're going to see an expansion of the indications for dual mobility in revision hip surgery, and as a result, do a better job for our patients. And with that, I'd like to thank you.